Medurstand-Understanding Medicine.
Professor Azizur Rahman here, and we have discussed mitral stenosis in some details and some of the concepts about the opening and closure of the valves and how these abnormal sounds are produced were discussed in mitral stenosis, and many of those concepts will be applicable here also. So I strongly recommend that if you have not watched that video on mitral stenosis, so you should watch that one first and come here later, because I will not describe some of those conditions, some of those concepts in that detail here. So today we're going to cover this mitral regurgitation. As the name says, it is the incompetence of mitral valve, and that is a relatively, again, a common condition, but at the end we will have a very brief discussion about my tricuspid regurgitation also, because I don't want to have a separate lecture for tricuspid regurgitation. This is the diagram. You can see that this is the mitral valve. Normally blood should never go back from the left ventricle to the left atrium. In left ventricular systole, the valve should close and should close completely, and no significant amount of blood should go back to the left atrium. If this valve does not close for whatever reason, then during systole, blood will of course be ejected into the aorta, but it will also be ejected back into the left atrium. Blood will find it easier to go to the left atrium because of lesser pressure gradient. So even minimal mitral regurgitation will lead to a lot of blood going back into the left atrium and then causing some hemodynamic problems, as we will discuss shortly. Etiology of mitral regurgitation. Those of you who have attended my first lecture, I said mitral stenosis is almost always due to rheumatic process, but in mitral regurgitation, I think still the commonest cause of mitral regurgitation in our part of the world is rheumatic. Then it could be ischemic. Why we and how we can develop ischemic mitral regurgitation? Because of the involvement of the papillary muscle. If you remember the normal physiology, during left ventricular systole, the pressure builds up into the left ventricle, and that much pressure cannot be sustained by very soft mitral valves themselves. It is simultaneous contraction of the papillary muscles which arise from the left ventricular wall and then are attached to the cusp through chordae. So it is the simultaneous contraction of these papillary muscles which prevent mitral valve prolapsing into the left atrium. So if there is ischemic damage to the papillary muscles, that could cause mitral regurgitation. Then degenerative, there are some disease processes where mitral valve can degenerate and can cause some connective tissue disorders, Marfan syndrome, Ehlers-Danlos syndrome. So these are the conditions where connective tissue may be abnormal and these valves become incompetent. And functional incompetence, functional regurgitation, but when valve itself is normal in structure, but it is incompetent, it is not closing properly because of some problem elsewhere in the heart. For example, if ventricles are dilated, imagine a case of dilated cardiomyopathy. Well, the chamber is dilated to double its size, and the mitral valve, although structurally normal, but will not co-opt with each other in the center, so that will result in incompetence. So functional incompetence. And then infective, of course, infective endocarditis can cause a rupture of the cusps. And the pathophysiology, very similar to the pathophysiology of mitral stenosis with some important differences. First of all, because mitral valve is not closing during left ventricular systole. So left ventricular pressure, because the blood will be a significant amount of blood will go back to the left atrium. Of course, the blood would go to the aorta also, but in the aorta the pressure gradient is high. In the aorta, pressure is higher than the pressure in the left atrium. So even with small regurgitation, small incompetence, a significant amount of blood from the left ventricle will go to the left atrium, and that will cause left atrial enlargement more than you get in mitral stenosis, because this time left atrium is subjected to the left ventricular pressure, which is very high. And then there is left ventricular volume overload. This is the important difference. Here the difference is that you have left atrial enlargement, which is likely to be more than that in mitral stenosis. But the big difference between mitral regurgitation and mitral stenosis is left ventricular volume overload. In mitral stenosis, I told you that there is no volume overload, there is no pressure overload in left ventricle, because left ventricle is not actually getting the normal share of work. But in patient with mitral regurgitation, these patients, they have volume overload. What is volume overload? When a ventricle receives more blood during the diastole and is overfilled, and then following the stalling light has to contract with greater force in the following systole. So how come that happen in patient with mitral regurgitation? During systole, some of the blood regurgitates back into the left atrium, and in the next diastole, that blood along with the blood received from the pulmonary circulation, they are going to come back to the left ventricle. So left ventricle is going to actually receive blood volume more than normal. So that would cause volume overload, and that would cause left ventricular dilatation, left ventricular enlargement, and that will actually be used as one of the features to differentiate mitral stenosis from mitral regurgitation. There will be pulmonary venous hypertension, just like we have in mitral stenosis, but in this case there will be additional left ventricular hypertrophy because of volume overload. Then again, just like mitral stenosis, these patients would go into pulmonary edema, and they will also go into left ventricular failure because the left ventricle is involved. In patients with mitral stenosis, you do not actually develop left ventricular failure. Although the symptoms may be very similar, but you actually develop left ventricular failure only in mitral regurgitation. That also, once it's all compensatory, its adaptive mechanism has been overwhelmed. Then there is right ventricular hypertrophy, right ventricular failure, and then there are frank congestive cardiac failure, dilatation of the veins, neck veins, hepatic congestion, ascites, pedal edema, scrotal edema, all that will develop. So ultimately the picture will be very similar, but the key differentiating point between mitral stenosis and mitral regurgitation is the involvement of left ventricle in the form of left ventricular hypertrophy and dilatation. That will help you to differentiate between the two conditions on the bedside, and also that will of course cause different kind of auscultative finding, so that is also important. Like in mitral stenosis, I told you this is the natural history. One difference between the mitral stenosis and mitral regurgitation natural history is that in mitral regurgitation, usually patients remain asymptomatic for quite some time because left ventricle has the great ability to adapt. It is adapting, it is taking up the extra load and keeping you asymptomatic. But once that adaptive mechanism is exhausted, once left ventricle starts failing, then there is symptoms, and then there is usually rapid downhill. Unlike mitral stenosis, patients with mitral stenosis, they tend to develop symptoms due to pulmonary edema. Once relieved, they go home, they remain asymptomatic for a long time, and then again and again they go and to the pulmonary edema, come out and live, and then like that. So that is a difference in the natural history. But in either condition, something can happen which can change the natural history, of course, for the worse. And these conditions are They were discussed in detail in the last lecture, but here I will just mention reduced cardiac output may result in hypoperfusion, malfunction of kidneys, brain, and other tissues. Atrial fibrillation, these people are highly prone to develop atrial fibrillation that will cause further problem and will predispose patient to thromboembolic phenomenon, and there may be actual thromboembolism, there may be stroke, or there may be gangrene, there may be renal infarct, there may be splenic infarct. So I think these emboli can go anywhere and can cause infarction. Mostly they would go to the brain and would cause stroke. And then these patients are also prone to develop infective endocarditis. These are the same complication which we discussed in greater detail in mitral stenosis. Symptoms are again very similar to mitral stenosis, initially well tolerated but later rapid decline. This point I have already explained. Physical findings are of course different. In this case, you would have heaving and displaced apex beat. You know that normally apex beat is felt in the fifth intercostal space, medial to the mid-clavicular line. Just medial. There may be a little bit of variation, but mostly just medial to the mid-clavicular line in the fifth intercostal space. Sometimes apex beat may not be palpable, depending upon the person, but if it is palpable, that is the area. And in this case, in patient with mitral regurgitation, it becomes heaving. Heaving means when it is lifted. When you put your hand on the precordium, your hand will be like lifted during the systole. That is heaving. And it will be displaced. That means the apex beat, which is defined as the lowermost and the lateralmost part of the precordium, which shows distinct pulsations. And they indicate actually the anatomical location of the apex of the heart. So apex would be shifted toward left and downward. Whenever there is left ventricular dilatation, apex beat moves leftward and downward. So you might locate apex beat in these patients in sixth intercostal space, lateral to more distal to the mid-clavicular line, even the anterior axillary line or mid-axillary line. I'm sure you know all this terminology. Soft first sound, I think the best way to remember is that first sound is produced by the closure of the mitral valve. Since mitral valve does not close properly here because of the incompetence, that is why the first sound is not of much intensity. It is softer than normal. Then it has got a very characteristic murmur. Those who examined one or two patients, they would, I think, remember it. Will never forget. It's so characteristic murmur. It is pan-systolic. By that we all know it means that the murmur is heard throughout the systole. It starts with the first sound, stays throughout the systole, is almost of the same intensity throughout the systole, and then ends with the second sound. It is soft and blowing in character, like this. So it is soft and blowing in character, and it would be best heard with stethoscope, the diaphragm of the stethoscope on the mitral area, but it would radiate to the axilla. By radiation, we mean that any murmur may be heard on a wide area if it is loud enough, but if it maintains its intensity in a specific direction, we call it radiation. So you will appreciate that the murmur is best heard on the mitral area. If you move your stethoscope by 2 to 3 inches toward the axilla, the intensity of murmur is the same. But if you move your stethoscope on the right side to the sternum, then the intensity reduces. So that is meant by radiation of the murmur. This is actually based on the hemodynamics of the blood, because blood moves back into the left atrium. Now if you consider that left atrium would be situated on the back side of the left ventricle, that is why it moves, radiates to the axilla. And it is best heard with the diaphragm. So I hope that gives you some reasonable idea, but of course you will not have the actual idea how does it sound unless you auscultate the patient. And so I think develop that skill. Now this is the picture will highlight some of the features of this murmur. This is the first sound, systole, second sound consisting of two components, then followed by diastole, then the cardiac cycle repeating. Now what happens in mitral regurgitation? Number one, you have a relatively softer first sound. You see this line I have drawn little shorter because of indicating that the first sound will be of less intensity, will be softer. And then there is a pan-systolic murmur. Normally in the systole there is no noise, there is no sound. But in patient with mitral regurgitation, there is a murmur which is almost the same intensity throughout and starts with the first sound and ends with the second sound. It actually ends even slightly later. So you may be unable to differentiate first and the second sound separate than the murmur. So it's pan-systolic murmur. And you can also appreciate that the pulmonary component has grown a little taller. So there will be pulmonary hypertension in patient with mitral regurgitation also. The pulmonary P2 component may be louder. So this sums up the auscultatory finding of mitral regurgitation. Soft first sound, pan-systolic murmur and loud P2. And the characteristics of murmur we have already discussed. Diagnosis mostly clinical. I think last time I said 90 out of 100. I think here I believe 99 out of 100 you should be able to pick up mitral regurgitation on auscultation. And these things are helpful, and we will discuss what we expect in ECG and X-ray, but ultimate investigation of choice is echocardiography. And now this is the X-ray. You can obviously see that there is massive cardiomegaly. You actually have to measure the heart size to be very sure. But if it is frank cardiomegaly, it should be obvious to your eyes even without measuring. But generally in the examinations, I think you must demonstrate that how do you know that this is cardiomegaly. You might figure out that there is cardiomegaly, but it is, I think, best if you can actually demonstrate to the examiner that this is cardiomegaly. Now I'm going to show you how do we demonstrate that there is actually cardiomegaly. So there is we just draw an imaginary line. You don't actually draw the line on the X-ray because that will spoil the X-ray. So just draw an imaginary line. And then you draw another line from the inner side of the thorax. Note down, this is from the inner side of the thorax. It should not include soft tissue, only from the ribs, inner side of the ribs, draw the line. This would indicate the maximum internal thoracic diameter. Okay, and this may be sometime even lower down, even below the diaphragm, but we have to measure the maximum transverse diameter of the thorax. Then we have to draw another line, or we used a measuring tape to measure this maximum transverse diameter of the heart. Now this has to be maximum as well as transverse at the same time. So you can't measure it like this. That would be perhaps maximum, but it is not transverse. You can't measure transverse from here because that is transverse but not maximum. So you have to find a point where you can have the maximum and the transverse diameter, and this is the point which I have identified. So from right cardiac border to the left cardiac border, I have drawn another line. So now if we compare the length of these two lines, normally this should have fallen behind this midline. Means that maximum transverse diameter of the heart should be less than half of the maximum transverse diameter of the chest. So that is how it works. In this case, it is definitely much more than half. So it means there's a frank cardiomegaly. That is why we could figure out on just inspection. But on examination, if you have to demonstrate, this is how you do that. Cardiomegaly in patient with mitral regurgitation. Why? Because there is left ventricular dilatation. There is left ventricular hypertrophy. That is why you get dilatation. That is why you get cardiomegaly. Ultimately, these patients, they have dilatation of right heart also. In this patient, I guess right heart is also dilated, so there is biventricular dilatation. That is why there is so much cardiomegaly. This is echo. Echo has got two components. One is just seeing the heart valves and structures, which I showed you in the last lecture. This is, of course, the interventricular septum. This is right ventricle. This is left ventricle. This is left ventricle posterior valve. We are looking at a long axis view of left parasternal, long axis view. And this is left atrium. This is aorta. Now, normally, there is flow from the left atrium to the left ventricle only, no backward flow. But there is some color coding, echo, this Doppler. The other component of echo is actually Doppler. Doppler can determine the direction of blood flow and can also determine the amount of blood flow. Now, this is actually coded in different colors. If flow in this direction is coded red and flow in another direction may be coded blue. Actually, it depends where your transducer is. So I think for you, the easy thing to understand is that this blue jet indicates that the blood is flowing from the left ventricle into the left atrium. This is an abnormal flow. So this is a Doppler part of echo. This shows that there is mitral regurgitation. Okay, this actually are the signs of aortic valve and other mitral tricuspid valve, but we are just discussing this one, mitral regurgitation. So you can not only determine the presence of mitral regurgitation, you can actually quantitate. You can actually have the pressure measured in the left ventricle, pressure measured in the left atrium, and you can determine the gradient, and you can actually measure the amount of flow. You can also measure the orifice size. So you can have a lot of information from echo. Mostly echo is transthoracic. That means we put our the probe here, but sometimes we have to do it transesophageal. With that technique, we have a chance of getting closer to the heart. Maybe we get a better picture, but that is little invasive procedure. It is invasive because you enter in somebody's body. So I think if the diagnosis is possible with transthoracic, we do not go for the transesophageal. But if the diagnosis is not clear, then transesophageal would be next step. Management. Many patients with mitral regurgitation may not require any medical treatment because they may not have any symptoms. Why? Because I said left ventricle has the great ability to adapt. There is mitral regurgitation, there is extra load on the heart, the left heart, left ventricle, but the left ventricle is very gracious to take that extra load and patient is not symptomatic. Only when it gives up, when all the adaptive ability is exhausted, only then patient goes into left ventricle failure and symptom develop. So at this stage, you may not need any medication, but of course it would depend person to person. If Doppler shows that the problem is quite advanced, then of course you need to do something. Then medical treatment, diuretics and digoxin, just like we discussed in mitral stenosis. Then surgical treatment. These patients, they would need an open heart surgery. They would need either repair of the valve or the replacement of the valve. I think this is a ultimate. They would prosthetic valves could be artificial or they could be organic. And I mentioned in mitral stenosis also, there is going to be a time very soon, I believe, when patient will be able to order a valve made from his own tissue using 3D printer technology. And this is the murmur of a combined condition. There could be actually mitral stenosis as well as mitral regurgitation together. So if that is the case, you would have the features of both conditions. This is a murmur of mitral regurgitation with all the characteristics we discussed earlier, and this is a murmur of mid-diastolic murmur with pre-systolic accentuation, murmur of mitral stenosis. So both features will be combined in one patient. Now, very briefly, mitral valve prolapse is a condition which is different than rheumatic mitral regurgitation, but it has got some interesting features and is common actually. It's still common, it's very common, less common than rheumatic, but it is common. A common condition in young people, mostly in girls, mostly those who are very skinny, tall. And in this condition, the problem is that the chordae are redundant. Chordae are redundant and they prolapse into left atrium. Now, otherwise everything is okay. When left ventricle contracts, this papillae muscles contract, they attach to the cord, the muscle, the cusp. But since these are redundant, that means they are longer than they should be. Then the point where mitral valve stops is actually already when they have prolapsed into the left atrium. So prolapsing into the left atrium would cause a regurgitation. Murmur is preceded by a click. There is a very characteristic click during systole. There is click followed by a murmur. And in these patients, actually, this murmur has got very interesting features. Any procedure, any posture, any maneuver which increases left ventricular size would reduce this murmur. For example, during Valsalva, during sustained hand grip, whenever you dilate this left, or you examine the patient and somebody raises the legs of the patient, and that would increase venous strength. So all these conditions, left ventricular size will increase, so that would result in lesser redundance, that would reduce the murmur. And anything which reduces the size of left ventricle, for example, use of diuretics, use of nitrates, or certain maneuvers when somebody suddenly stands up. When you suddenly stand up, the blood stays in the veins and less blood comes to the heart, and the heart size becomes smaller temporarily. So all these conditions, they increase the intensity of murmur. So I think these are some interesting features where we can differentiate mitral valve prolapse from mitral regurgitation. This is generally considered to be less serious condition and treatment is usually conservative, but I know some patients, they may develop severe symptoms. These patients, they may actually develop all those complications which we normally associate with rheumatic mitral regurgitation. Treatment is conservative. These patients are asked to drink a lot of water, keep themselves hydrated, and not to use diuretics, not to take those medicines which reduce heart rate like nitrates, digox. Sometime I think a repair may be needed because it is possible to reduce the size of this chordae. Tricuspid regurgitation, I think just one slide, that is usually secondary to right ventricular dilatation. Of course, it may be due to some primary problem like carcinoid syndrome can affect right-sided valve. Some anti-obesity drugs, they predominantly affect a right-sided valve. But mostly this tricuspid regurgitation, patient with IV drug abuse, I think that is an important condition that could affect the right-sided valves. But mostly it is secondary to right ventricular dilatation, which again is secondary to pulmonary hypertension, and pulmonary hypertension may be a condition in itself, primary pulmonary hypertension, or pulmonary hypertension may be due to some left ventricular disease. So tricuspid regurgitation is usually secondary to some other disease. The murmur characteristic would be the same as mitral regurgitation, soft and blowing, but it would be best heard on the left lower sternal border, would not radiate anywhere. There may be V wave on the neck. If you examine jugular veins carefully, you might see this V wave because with every right ventricular systole, blood is leaking back into the right atrium. So that is causing a V wave. And if you examine the pulse, you would appreciate that the liver, if you examine the liver, you will appreciate that the liver is enlarged and is pulsatile. There are other causes of pulsatile liver also, but in this case, if you put your hand on the right, this is what we call right hypochondrium, we place your hand here and you feel the liver, and you will feel that with every systole the liver expands. So that is pulsatile liver. I think these signs will help you to make a very easy diagnosis of tricuspid regurgitation. So that was it. We covered mitral regurgitation in detail, but we also discussed mitral valve prolapse, which is one of the types of mitral regurgitation, and very briefly we discussed tricuspid regurgitation, and we have already covered mitral stenosis in my last lecture. I hope this was useful. I hope you learned something new, and I really look forward to see you in my next two lectures, which will be on aortic valve, first aortic stenosis and then aortic regurgitation. Till that time, you look after yourself. This is Professor Azizur Rahman from Medurstand. Thank you.